A 49-year-old woman presents to the emergency department with a one-day history of headache, vomiting and confusion. She has no significant past medical history. On examination you note normal chest and cardiac auscultation. She has a normal peripheral nervous system examination. On fundoscopy you see retinal hemorrhages. Her observations are recorded as heart rate 89 beats minute, blood pressure 190 by 130 mmHg, respiratory rate 18 breaths per minute, oxygen saturations 97% on air, temperature 36.2 degrees Celsius. What is the recommended initial treatment for this patient? Options are A. Oral atenolol, B. Intravenous nifedipine, C. Intravenous nimodipine, D. Intravenous leptilol, E. Intravenous phentolamine. Answer is D. Intravenous leptilol. Accelerated, malignant, hypertension, hypertensive encephalopathy or intracranial hemorrhage. The term accelerated hypertension, also known as malignant hypertension, is a subcategory of hypertensive emergency where severe hypertension occurs with retinopathy of grade 3, flame hemorrhages, dot and blot hemorrhages, hard and soft exudates, or grade 4, papilledema. Hypertensive encephalopathy encompasses the transient neurological symptoms that occur with malignant hypertension, which are usually reversed by prompt treatment and lowering of BP. Leptilol is the first-line treatment for accelerated, malignant, hypertension, hypertensive encephalopathy, or intracranial hemorrhage. A 34-year-old man presents to the emergency department after developing palpitations during a 5 km race. On examination his heart rate is 185 beats per minute, BP 83/54 and RR 20 breaths per minute. He reports no loss of consciousness, breathlessness or chest pain. He has no significant past medical history. Which of the following treatments is most appropriate for this patient? Options are A. Synchronized DC cardioversion, B. Amiodarone 300 mg IV, C. Metoprolol 5 mg IV, D. Adenosine 6 mg IV, E. Verapamil 5 mg IV. Answer is synchronized DC cardioversion. The ECG and history are consistent with re-entry paroxysmal supraventricular tachycardia, SVT. The patient is hypertensive. This is an adverse feature, and therefore synchronized DC cardioversion is indicated. A 49-year-old man presents to the emergency department with a 3-hour history of palpitations. He has a past medical history of mitral valve disease and hypertension. On examination you note an irregular pulse. A 12-lead ECG confirms atrial fibrillation. A decision is made to chemically cardiovert the patient. Which of the following drugs is most appropriate for this patient? Options are A. Amiodarone, B. Flecainide, C. Digoxin, D. Adenosine, Verapamil. Answer is A. Amiodarone. If pharmacological cardioversion has been agreed on clinical and resource grounds for new-onset atrial fibrillation, offer a choice of flecainide 50 to 150 mg or amiodarone 300 mg to people with no evidence of structural or ischemic heart disease or amiodarone to people with evidence of structural heart disease. You have been asked to give a teaching session to a group of medical students attached to the emergency department. You are discussing valvular heart disease and murmurs. Which of the following is not a typical feature of tricuspid regurgitation? Options are A. Atrial fibrillation, B. Prominent A waves in JVP, C. Pansystolic murmur at left sternal edge. D. Third heart sound. Answer is prominent A wave in JVP. Clinical features of tricuspid regurgitation. Patients are usually asymptomatic unless right heart failure develops and the patient complains of edema, ascites and abdominal pain from liver congestion. Pulse, AF common, large, V, waves in JVP. Auscultation, soft pansystolic murmur at left sternal edge louder on inspiration, third heart sound. Other features, tender enlarged pulsatile liver.